Okay, thank you so much for joining in today. Good afternoon once again. We appreciate our content expert is already here. Good morning, Doctor. We're happy to see you here. So today we are going to have a discussion about psychiatric comorbidities in children. But before we start the discussion, I'm going to share my slides to take us through or to introduce what these sessions are just before the case presenter comes in to present the case. Thank you. Okay, so these are continuous medical educational series organized by the Eastern African Young Psychiatrists Association and Trainees Association. This is an association that brings together young psychiatrists and trainees in Africa. So today we are having Dr. Patricia Nankunda, who is a resident in psychiatry at Mbara University, and the Associate Professor Dr. Rukundo, who is also a psychiatrist, but a child and adolescent psychiatrist from McMaster University. This is our very first session for this series. We shall be communicating the next session. We shall be having one session every month, and we shall be communicating in the course of the month. So here I'm just highlighting some of the key objectives of EAYPTA, and the ones which are bolded are the ones that we are trying to realize during these sessions. That is regular interaction with medical health workers in the region and beyond. As you can see, we have an expert from Canada. So we are trying to expand our horizons to involve specialists across the world and to promote professional, academic, social development and among young psychiatrists in East Africa through regular meetings, conferences, seminars, and workshops, just like this one of the CMEs. So EAYPTA is affiliated to the mother institutions or the mother associations, that is the Uganda Association of Psychiatrists from Uganda, the Kenyan Psychiatric Association from Kenya, and the Rwanda Neuropsychiatric Society and Tanzanian Psychiatric Association. So we work under our mother associations. The committee running 2025-2026 is this one displayed here. Our president, Dr. Isaac, I think he's on call or should be joining us shortly. I've seen the treasurer from Uganda, Dr. Dorena, she's on call. Dr. Tenge Angeline, our Secretary General from Kenya, and Dr. Samuel Kamochi from Kenya. I think they are all on call. Dr. Emmanuel, our Vice President, and then the executive members from Uganda, Kenya, Rwanda, and Tanzania. So that's the team that has organized this session, and we really appreciate these sessions. So EAYPTA constitutes a variety of experts across the world, where we have the senior psychiatrists and mentors who provide mentorship to the young psychiatrists and trainees. So this was one of our annual general meeting, which was there in Eldoret, Kenya, just last year. So I will stop here and hand over to the case presenter to take us away. Thank you so much. Please enjoy the session. Dr. Patricia, you can go ahead to reshare your screen again. Yeah, we can see the screen.
Thank you, Dr. Moses. Good morning, Professor, and good afternoon, everyone. As Dr. Moses has already introduced me, I'm Patricia Nankunda. I'm a third-year resident at Mbara University of Science and Technology, and I'm going to be taking us through a case presentation. So I'm presenting NM, a 13 years old female from Kabo Heshema. She's a Mnyankore, a Pentecostal. Level of education, she's in a special needs school, and we couldn't ascertain which level she was in. The next of kin is KJ, who is a paternal aunt, and they were admitted on the 13th of February, 2026. She presented with a 1-week history of being aggressive, and she came in as a transfer from pediatrics outpatient unit of Mbari General Referral Hospital. She had been unwell for a period of about 10 years and was brought in with a history of being aggressive towards her cousins, aunt, classmates, teachers, and any other person who would disturb her. So NM was conceived through natural conception. The mother had no pregnancy-related complications. She delivered her at 9 months by vaginal delivery, and both mother and child were in good health condition and they were discharged home. She achieved age-appropriate milestones up to the age of 3 years and had also started school by the age of 3 years and was staying with her mother, who at that time had separated with her father. At the age of 3 years, she had cerebral malaria and was treated with quinine injection, after which she reportedly became deaf and dumb, according to her aunt's verbal report. When she became deaf and dumb, the mother abandoned her at her paternal grandmother's home, and later the paternal aunt offered to take care of her and brought her to live with her at her place. While at her auntie's place, the aunt noticed that NM was eating from the garbage pit. She was also going to the neighbor's kitchen and serving herself food from the fire without asking. She did not like bathing and would also wander away from home and come back with scratches and cuts on her skin. She was always taken to church for prayers and would temporarily improve. And at the age of 5 years, her ears brought a watery, foul-smelling discharge, and she regained some hearing. She mumbled a few words she had already. That time it was close to a new year, so she had Happy New Year and she said it, but this did not last long. She also was able to say a few words during that time. This didn't last long, and a week later became dumb again, but the hearing was maintained. During this time, she stopped eating from the garbage pit and serving herself neighbors' food and started asking food from her aunt at home by bringing her a plate or a cup every time she would feel hungry. She also started helping with chores at home. Every time she could see someone doing something, she could go to help but could not initiate activity on her own. Like she would see her cousins doing chores, washing dishes, and she goes to help, but she could not go to start washing dishes on her own. Though she could do chores very fast when she's like washing dishes, she's doing it very fast like she's going somewhere. When she's going to the garden, they said she would weed, and in case they were weeding beans, she would even remove the beans that were being, that were supposed to be left behind, and she was doing it very fast compared to other people. Though sometimes she would do things perfectly, most times they were not perfect. Like the aunt reported that when you give her to sort beans, most times she sorts, and after sorting, she mixes them again. But she had times where she could do things perfectly, though it was on and off. Later on, the aunt convinced the dad to take her to a special needs school so she could learn some sign language, which the dad agreed to, but when they tried to put her in school, she would escape looking for her aunt. And most of the schools didn't have fences, so she could just escape and go through the bushes. And every time she would show up with bruises on her skin. So they finally got her a place which had a fence and it could contain her. But a week after staying in school, the aunt was called by the school authorities to take her for assessment so she could be started on medication like most of the students in that school. Because every time she was fighting classmates on just slight provocation because she couldn't hear, so they were disturbing her a lot. And every time they would disturb her on slight provocation, she would start fighting or beating them. And when the teachers also stopped her from getting outside, when she's tired of class, she would just want to go outside. And when she stopped, she would also beat the teachers. So the father was informed and he went and picked her up from school without the auntie's knowledge. took her to a medical facility, which is not known to the aunt, whether a hospital, a clinic, or a health center, where she was initiated on unknown medication. And she responded to the treatment according to the people at school and also to the aunt when she came back home. But when they broke off for holiday, she did not come back with the medication, but was okay compared to how she went to school. The aunt noticed during the holiday, she had episodes of being extremely happy, that she would drum the whole day, dance, and hum most of the local songs. And the aunt says she knows most of the local songs. She can't pronounce the words, but when she's humming, you know what she's singing. The aunt also reported that she would try to speak to them, but when they failed to understand what she's saying, this could make her angry and also would easily make her fight them or beat them up. And sometimes she would just become sad and isolate herself or self-injure herself by biting herself until a chunk of flesh falls off, or she would scratch herself until she bled. She was then taken to church, and the pastor advised them to make her dry fast. And while fasting, the above symptoms subsided according to the aunt, and she became a bit calmer and more cooperative while at home. A week prior to admission, she became more aggressive, restless, and would not stay in one place, could only try if the aunt gets a stick and threatened to beat her, which I also witnessed when I was clerking her at the hospital. But then this couldn't really last long. She would stay there for like about 5 to 10 minutes and then get up and try to grab things in front of her. She also had disinhibited behavior like urinating in front of people, which she also did yesterday while we were on the ward round, and also started biting and scratching herself. And one of the relatives had come to visit and advised the aunt to bring her to Mbarara Regional Referral Hospital for assessment. Though they first went to the pediatric outpatient unit, and that's how they were transferred to psychiatry. We couldn't ascertain if she was hearing voices of unseen people or seeing things not seen by others, but the aunt reported that during the other 1 week history at 5 years, where she was able to speak, she would be seen talking to a wall and laughing like she's having a conversation with someone, but that has not happened since then. However, her sleep and appetite have been unaffected, and she was playing and interacting with her cousins at home well prior to this episode. Her cousins are aged 10 years and 6 years. So the past histories, per psychiatric history, this is the index admission to a psychiatry unit, but has had multiple episodes with slight improvement in between episodes upon praying for her. And then past medical history, no known chronic illness as per now, and she's not on any other chronic medication. So family history, she's the firstborn in both parents who separated shortly after she was born. Her mother's whereabouts are not known, and she has never come to even look for her. The father has another family, but checks on her occasionally, both via phone and physical visits. She currently stays with her paternal aunt, who is married with 2 children who are aged 10 and 6 years. And she has a positive family history of mental illness in the paternal cousin who has anger issues and is currently on treatment. But that's all I could get from the aunt. The other symptoms she's not aware, but she's aware that he is on treatment and he's currently doing well. So the mental status exam on admission, she was fairly kempt, though easily distracted, looking around the room and trying to pull everything around the room. She would smile and try to make eye contact while being talked to, though it could not be maintained for long. Would also put her tongue out while laughing and while laughing inappropriately and squinting her eyes or is touching her anal area. It wasn't scratching, but touching. Speech was present, but incomprehensible. We couldn't really comprehend what she was saying, but she looked happy. I couldn't assess other parameters of the mental status examination because of her speech. Our working diagnosis, our working diagnosis at the moment was autism spectrum disorder, comorbid attention deficit disorder with a differential of attention deficit hyperactivity disorder, comorbid intellectual development disorder. So our treatment, we started out tabs carbamazepine 100 milligrams twice a day and tabs risperidone 1 milligram twice a day. And on the third day of admission, which was the 16th of February, the aggressiveness had stopped but couldn't reciprocate emotions. When you talk to her, she couldn't really reciprocate or smile to her. And her eye contact was still poor, still had disinhibited behavior, and was still wanted to run away. On the 7th day of admission, which was yesterday, the 20th of February, she also still had disinhibited behavior as she came and urinated in front of us when we were doing a ward round, and still wants to go away, and or is pulling things in front of her, still not able to reciprocate emotions, but was a bit calm compared to the first day of admission because she came and sat when we were seeing her and then fell asleep a bit while we were assessing her on the ward round. So that's all I had for the case presentation. Thank you for listening.
Thank you so much, Dr. Patricia. Thanks for compiling the case. It's an interesting case, but we shall get feedback from the content expert. So today we are going to have our session divided into 3 sessions. The content expert the case presenter has finished presenting the case. After this, we shall get questions and input from the content expert to try to more contextualize the case and help us in the best way to manage. And then after that, we shall get questions. We shall go into the Q&A session. So allow me to introduce to you our professor, Dr. Rukundo. He's an associate professor of child psychiatry, child and adolescent psychiatry at McMaster University. And he has been teaching psychiatry for many years, not only teaching, but also doing research in child psychiatry. We are really grateful to have you, Professor, on call today. And again, we really apologize for the short notice, but we are humbled for your acceptance and being with us today. So without wasting any time, I would like to hand over the microphone to you for the next section. Thank you.
Yeah, thank you, Moses. I will apologize that I will not put on my video. I woke up late, so I didn't prepare for the video. Are you getting me?
Yes, we are getting you clearly, and apologies accepted.
Yes, so yeah, it's a bit, it's just about, it is now coming 6:30 in the morning, so I thought I would wake up early and I didn't.
Oh, sorry.
Because I was busy the whole day yesterday. Okay, so I'm happy to be part of this discussion. And for those who may not know, I must say I'm one of the founding members of EAYPTA more than 20 years ago. So I'm happy to see that it is still moving on. And when we started it, we were feeling like left out as trainees, because that time we had only the seniors meeting and we couldn't fit in. And by then it was only Tanzania, Kenya, and Uganda. So we decided to form this association to bring us together, and we enjoyed ourselves. I remember changing the rules to make sure we stay in the association until we couldn't change it anymore. So I'm glad that it's still moving on, and seeing the membership is so encouraging. So And I want to thank you for having such discussions. It is very helpful. And thank you, Dr. Nankunda, for that presentation. So I think I want us to maybe few changes in the program. I want to ask some questions.
We have lost the audio.
Then we discuss them. Dr. You presented that she had even gone to school and then she got malaria, and that's when this problem started. Could you say? Could you clarify that?
Yes, Prof. At the age of 3, she had just started nursery, and then that's when she got cerebral malaria, but everything was okay before the cerebral malaria.
Okay. Okay. So, thank you for that. So then I'll go to what I wanted to give as my last question, and I ask it. So, and then you said your work the autism spectrum disability and something like you. What made you think that this was autism spectrum?
Prof, I lost you a little bit. I didn't get the question.
You just like tell us your
Prof, we are finding
diagnostic
there is a
criteria.
network.
The diagnostic criteria that you used. Like, are you not able to hear me?
Oh, we lost you a few minutes, a few seconds ago. Now we're hearing you.
Like I wanted to know what features
Yes.
made you think that
We are still finding the audio is still breaking.
I think I picked what Prof is trying to ask, that which features did we consider for diagnosing autism spectrum? Is that the question, Professor?
yes, exactly that one. Yes.
Okay, so Professor, we used, according to DSM-5 TR, we considered there has to be at least an individual must meet criteria in the two main aspects, which one of them is social communication and interaction, of which one of them was her eye contact was really poor. That's what we considered. And the other one was repetitive and restricted behavior. So at some point, we thought the drumming, because they said it would happen on most of the days. So we're like, was she just having manic episodes or so? Yeah, but Prof, that's what I considered, and I stand to be corrected. Oh.
Yeah, maybe if I can add on that, and I think
Yeah.
we interacted with the patient yesterday again, and still she lacked that emotional reciprocity. So
Reciprocation.
when you talk to her, she does not look at you. She fails to kind of have you can't have a back and forth conversation with her. but also she talked about the stereotyped or repetitive motor movements in history. And then when she's doing something, she kind of goes into her own world and becomes fixated on something without really engaging with the environment as other normal children. Yeah, they are. I think the nonverbal behaviors also were not really matching the verbal behaviors, although the speech was impaired, but you could see there was no facial expression. So her feature is a bit tricky because she can't speak, and the features are not consistent. Like they are intermittent. Sometimes she kind of reacts, and then sometimes she's off. So it was a bit of a confusing image the few minutes I interacted with her. There are residents from psychiatry here who probably, if you have anything to add, you could raise your hand and I unmute you. Hello. If we cannot hear you clearly. Hello. Okay. Yes, Prof. Yeah, maybe he's facing some challenges with the audio, but I think he's going to sort it out. But we request for more questions as we have the discussion. We request for more
So,
questions
so I
in the
am
chat.
trying to change from the phone to the laptop,
Oh, okay.
but it is telling me the host is not allowing participants to unmute.
Oh, yes. I didn't communicate that, but I've allowed you to unmute now. You're able to unmute. Sorry for that.
So is this clear?
Yes, Pro. It's clear.
Okay, that's good. Yeah, so the reason I was I was interested in the diagnosis is, as you know, autism spectrum disorder and other neurodevelopmental disorders, they tend to come from early development, and they are not necessarily appearing later on in life, unless if there were some symptoms which were missed, maybe in early childhood. But if this child was very normal until 3 years, could it be that maybe the parents had not paid attention to the deficits? Or could it be that we are just looking at the sequelae of malaria, whatever she suffered at 3 years, other than just thinking of only just as autism? That's why I was asking the questions. And in the same vein, what made you think that this was ADHD?
Okay, so thank you, Prof. On assessment and even in history taking, from what the auntie was telling us, when they are working, she's usually working first, like she's going somewhere, she's so hyperactive, and her attention is a bit impaired. When you sit down with her, she cannot step. She's easily distracted. Even that time when we were clerking her, she was pulling things in the room, moving things from one place to another until the auntie got something to scare her. And she's like, this always works. I don't beat, but when she sees it, she knows I'm going to beat her. So she tries to sit in one place, but she also cannot last in that one place. So we also considered that because of, yeah, those. And also the other part of not paying attention was of doing things and not doing them perfectly. And we were like, let's consider attention deficit hyperactive disorder as part of our diagnosis. My colleagues can add.
Okay, so I think they are still thinking. Just looking at that explanation you've given, that the aunt would have a stick and scare her. So I was just wondering actually about the history of abuse as this child was growing up. For the child to fear the stick, it must have been used on her. So I was just wondering whether this child has been basically brought up by the stick, or like maybe because they are struggling to cope up with her behavior, or whether they have used the other ways of helping her to learn behavior other than scaring her with a stick. But also a child who was abandoned by the mother, and the mother has never come back. I needed to know, how did she like grow up? Who stepped in to take the role of the mother from that time until the aunt took over?
Yes, thank you, Prof, for these questions. The first one is, the aunt admitted to beating her. She said at first I didn't know what was happening, and I beat her a lot until we used to go to church, and they're like, no, let's pray for her this, let's pray for her that. But then when it's too much, she says, I beat her, but not always. But when you look at their relationship from how she responds to her aunt, it's not like, I don't think there was that form of abuse whereby but I know she knows when a stick comes, I've done something wrong and I know I need to behave myself. But without a stick, you see the way they are relating is, from the way I saw, Professor, is there is nothing like, okay, there might be abuse. I don't know, in Africa, I don't know where we draw the line between physical abuse and disciplining with a stick. But I actually, when you read her body language around the aunt, she's free with her aunt. And every time she would go pick things from her cupboard, she keeps bringing them to the aunt. She brings things from our bags and gives them to the aunt. So I thought maybe the stick was for correcting her and not abuse. And then I had put it in history, Prof. The day the mother dumped her at the paternal grandmother's place, the aunt was informed and the dad was also informed, but the dad wasn't willing to take responsibility. So the aunt then had not gotten married yet. So she came in and took responsibility of being a mother. That time she was actually working in Kampala. She first took her to Kampala, and they even tried to look for schools in Kampala where she could go, but she was not being admitted. They kept on telling her, this child cannot be accepted, we can't handle this. She even had to quit her job in Kampala, now came and fully settled in Shema to take care of this child, and has been with her since the age of 3. Yes, Prof.
Okay, thank you. And you mentioned that this child would have episodes where she would do things like appropriate things, like behave appropriately. And I was wondering, like, under what circumstances would she behave appropriately and for how long? And also if there were any history of seizures.
Okay, thank you, Prof, for the question. There was no history of seizures. And the aunt reported there are episodes where she would be normal. She even repeated it yesterday on the ward round. Like sometimes she wakes up, she's doing things normally. You tell her to sort the bin, she will sort them perfectly. But it's only the digging that she cannot, the weeding where she cannot know this is a weed, this is an actual plant. But it lasts for a very short time. That's what the auntie said. It's always on and off. So I forgot to ask the exact time, but she was like, it is always brief, but there are times where she really actually does things like a normal person.
Hmm.
Yes, bro.
Yeah. And what did the pediatricians think of this child?
They actually didn't assess, they just told her, you go to psychiatry. She didn't come with a paper, anything written. She just came. She's like, they told me to come here. So we started afresh. There was nothing they were told. They said it's a psychiatric case.
Hmm.
Yeah.
Okay. And the other one I was thinking about is you said she was touching in her anal area,
Yes, bro.
and I was not sure whether it was like just maybe some like she was itching and she was trying to help herself, or whether she was touching there like somebody who has been sexually abused. I wasn't sure how you observed it.
Yes, from the way she was touching, she wasn't scratching. It's like, I don't know how to explain, like she was trying to pull something, like maybe her cloth had entered. So, but she kept on doing it repeatedly. And at some point, she would even do it when doing other things, like because she was looking around, and then before you know it, she's putting her hand there and pulling out. She was wearing a legging. So I was like, was it what was entering and irritating her? But it wasn't like she was itching but she was pulling out something like it had gotten stuck in between there.
Hmm.
Yes, prof.
Okay, so what I was basically concerned about is that this child developed these problems after she got that condition they called malaria. I believe maybe she had fever or other features of malaria, or they just saw the behavior changing and they thought this was malaria. So I was thinking that we could be dealing either with the squarely of malaria or whatever caused that fever they called malaria if it wasn't diagnosed in the hospital. Um, Rather than saying this is something neurodevelopmental, like something the child was born with. Um, but also, like there was no clear history about um, like whether the mother was drinking, whether we are looking at like the fetal alcohol syndrome, um, yeah, such things.
Yes, thank you, prof. And we don't really know much about the mother because by the time she brought the child, they had already separated with the father. I think the father would just maybe check on the girl once in a while because even here, the aunt says he calls her once in a while just to call to check on how is she, and also comes like once or twice in a year to check on her, but he's not. So nothing much is really known about the mother, the drinking, but she was told by the dad that this all started after she was given a quinine injection following cerebral malaria. The aunt knows some English, so she's actually the one who said cerebral malaria and was given quinine, and that's how everything started. But how the child was sick and everything, I couldn't really assess because the aunt didn't have much knowledge about it.
Oh, I think I had actually missed the quinine thing. So this could also be due to the quinine, the effect of
Yes.
quinine, rather than just the malaria.
Okay.
It was an injection, not an IV, whatever, not an infusion.
We couldn't, she just told me injection. I don't know if it was an infusion but she's like, injection of quinine.
It's an
So,
injection.
Yeah.
Okay, yeah. So now those are many issues because even quinine can damage the brain depending on how much they have given and how the child has responded to it. But also it could be that maybe what the child was having was not malaria, but was maybe meningitis. I don't know whether it was viral or bacterial, or it could have been cerebral malaria. I don't know whether this was in the hospital or just in a small health facility. So I think there were many issues at that age of 3 years when she got that illness, and that could be the main issue. Yes, so looking at some of the features, like if you think of autism, you've mentioned the issue of poor eye contact. They appear like shy. They find comfort in being by themselves and engaging themselves, and they find it difficult to engage with other people or to initiate relationships. And they don't understand like a lot of social cues, especially if they are severe. They have severe autism. But of course, you also find those who are okay, who are able to interact meaningfully with other people. So, but from what you're describing, if this was autism, this would be like something more, maybe moderate to severe. And sometimes they become aggressive because they are looking for something to, like how to express themselves. They become aggressive because they are misunderstood or they don't know how to express themselves for what they need. And sometimes they do things for self-stimulation rather than just wanting to hurt anyone or do something because they are hearing a voice or something. So you may see the behavior as abnormal, but maybe it helps them to stimulate themselves. Then in terms of treatment, generally, the core symptoms of autism are not treated with medication. Medications just come in to treat the symptoms, like the behavioral symptoms or the difficulties, but otherwise you cannot improve some of the things with the medication, but rather they are supposed to have like support, psychological support, like therapy and behavior modification for them to be able to know what is appropriate and what can be helpful to them as they grow. But indeed, as you said, risperidone is one of the medications that helps control some of the behavior if they are dysregulated. And I must admit that it is difficult in our setting to have many medications that could be more helpful in this case. And I noted that you were giving risperidone. I don't remember the dose you were giving. How much are you giving?
1 milligram twice a day.
Okay, 1 milligram. And what have they noted as the improvement when you give?
The aggressiveness has reduced, and she's not as restless as she was on admission.
Mm.
And on top of that, Prof, we also added carbamazepine because we're also querying ADHD. And at the moment of admission, there was some financial constraints. We would have gone for methylphenidate, but they didn't have money. And even convincing them to stay on ward, they didn't want they kept on saying until they gave me and I talked to the father to give some support of at least food and just a few things to keep them on ward. So, and methylphenidate is about 3,000 a tablet. So, well, we try to improvise with carbamazepine, as maybe we wait for your opinion today, Professor, to guide us more about that.
Yes, of course, you said there are financial issues, and I understand that. And also the other challenge is that I think, I don't know whether now in Butabika we have the long-acting methylphenidate, or whether we are still having the short-acting. So it becomes very costly to have the short-acting because you need it every few hours. But I don't know. Is there anyone from Butabika here? I had seen Joyce. Joyce,
We
are you
have
still here?
Dr. Joyce is, yes.
Namase, are you still here? Anyone else from Butabika? Or in Kampala, to see whether we have like the long-acting methylphenidate? No one. Okay. Dr. Chirabira, do you know?
Yes, doctor, I'm on. I had failed
Okay.
to unmute.
Okay. Thank you. But now you have unmuted, yeah? So you can unmute again.
Okay, doc.
You have muted again. Okay.
And unmute, yes.
Yes. So do you know if we have like the Consulta or bifentin in Butabika, like the long-acting form of methylphenidate?
I'll have to find out. I'm not
Mm.
sure. Pardon the
Yes,
name?
like it's called Consulta
Concerta. Okay, doctor, I'll find out.
or bifentin.
Bifentin.
Those ones last like at least like for 8 or 9 hours. But the methylphenidate we used to have, the Ritalin, would last for a short time, like 4 to 6 hours. So somehow you need like 2 doses in a day. But the long acting you require like once in the morning, and that's fine. But of course, it's expensive. But we can also hear from people in the region. How is it in Nairobi? How is it in Kigali, in Tanzania? How is it? Are you also using carbamazepine for ADHD? Or are you having the other medications you can use?
I saw a comment from Malaika Kamenjo. I don't know that is still on, but she was asking curiously why carbamazepine. Maybe we could know why. Was curious about carbamazepine and better options in the area. You're all able to unmute, so you can go ahead and unmute and speak.
So I can just comment on carbamazepine. That is like off-label use of carbamazepine because we were stuck with nothing to use. And there have been some studies to show that there's some effect on ADHD symptoms when you use carbamazepine, but it is not the recommended medication for ADHD. It is just being used off-label. Otherwise, we have the psychostimulants as the mainstay, as the main medications, and methylphenidate-based preparations are the main ones. They are the ones which have been studied very well. And as I mentioned, we have the short-acting methylphenidate, the commonest brand being Ritalin. And then we have the long-acting preparations like Concerta, as I mentioned it. Concerta is CONCERTA. And then we have the bifentin. We have others like Foquest. They are all based on methylphenidate and made by different people, but generally being the same. And then we have also those which are based on amphetamines, or amphetamine derivatives, and like the main ones we commonly use are being Vyvanse, one called Vyvanse, and Adderall. I think those are the most common, but you may not find them like in Mbarara. At least from the time I was there, we didn't have any of those. And then we have what we call the non-stimulant medications. The non-stimulant medications, we have like clonidine. As you remember, clonidine is an antihypertensive, but is very good with ADHD, but in smaller doses. And then we have one called guanfacine. Guanfacine, or the trade name is Intuniv, the one we commonly use. And then atomoxetine or Strattera. I think Strattera may be available in Uganda. I was talking to one of the pediatricians a few months ago, and I think they were using it in Mbarara. So like those non-stimulant medications are not the best, but we commonly use them when a child is not able to tolerate the stimulant medications, especially if they are losing a lot of weight or if they are having severe appetite suppression, or if they get other reactions. Yes. So I think I've answered that question, Moses. But I wanted to hear from other people in the region. What are you using? Because I know some of these medications may take some time to get to where you are.
Hello, Godfrey Zari.
Moses, did you say everybody is able to unmute?
Yes, there's someone who was saying something.
I had seen Dr. Bengana. Is she still here?
Yes, I'm here.
Yes, nice to see you. I
Good
haven't seen
to
you for a
see you
long,
too.
long time.
Many years that you left us. You left us here.
Yes, you have been everywhere. You have been everywhere, WHO, everywhere. So tell us guide us what we can use in Uganda and Kenya and Tanzania.
I really cannot say. I really
Yes.
cannot advise you there because this is where I came to learn because I've not been a
Okay.
clinician. I've been in public health. I would
Yes.
need to go back and research, but I had the same
Yes.
questions people were asking about carbamazepine, for example. I was also wondering about that diagnosis of ADHD.
Yes.
I was wondering about, why the carbamazepine first when you are saying that it could be autism spectrum disorder. I also didn't hear anything at all about the behavior. Is there
Yes.
anything you are doing for this child in the area of behavior management? Because, as you know, for some of these, sorry. Sorry, I have some work going on here. As
No,
you
it's
know,
okay.
for children, we try not to get into medicating them too early, trying other options like behavior. So I'm hoping I can hear something on that as well. What is available to us and what could be done for this child? A very interesting story. Very often when mothers and fathers abandon a child, it's because they know that something is going on. So the question is not that something happened suddenly at 3 years, I don't think. I think they had noticed, the mother may have noticed something is going on, and hence the abandonment. Sorry.
Yeah, that is, I was wondering as well, why would a mother leave the child of 3 years and doesn't come back at all? There must be a problem. Okay. And Dr. Sechimpi,
Hello.
Yes, Dr. Sachimpe.
I didn't raise my hand, but it is nice to hear from you and Professor Rukundo
Yes,
and
I'm
the
happy
others.
to see you.
I'm still around.
Yes, I haven't seen you almost 20 years, so that's why I was happy to see your name.
Okay, thank you.
Yes.
So, Prof, I think the behavior interventions, I would say we hadn't really focused a lot. We knew that we need them, but I think we the setting really requires us as residents, for example, here to administer the interventions ourselves or teach the mother, because I think what has been done so far is psychoeducating the mother, but the behavior interventions to help the child haven't really been very much like started to direct it towards the child. So we would like to know, in this case, when the child is not hearing very well, what's the best, what are the best behavioral approaches that we can use when because it seems, and there's history of having an ear discharge. So we don't know whether the child is also not hearing in addition to other behavior challenges. How effective can we engage the child and the aunt in regards to the behavioral treatment?
Dr. Moses, I'm sorry to cut you short. The
No,
child hears. She hears. Even when you call her, she will turn. The aunt told me when there was a time when guests came around and she had not washed her undies and she had piled them somewhere. So she overheard the auntie tell the guest that, oh, she no longer wants to bathe and take care of herself. So by the time when the guest left, the auntie went to check on her and found her washing her aunties after hearing them talk about her. So she says she actually hears, but the problem
Great.
is speaking. Yeah.
Okay. Yeah, I interacted briefly with the child, so good you've clarified that. But even if maybe my question could still stay in case there's a communication difficulty. How
Okay.
basically it can be. Yeah.
Yes, so I think we will need to discuss that, the behavior interventions. So one, the having autism does not necessarily mean that the child is having intellectual disability, as you may know. We have people with high functioning autism, people who are actually exceptionally intelligent, and yet they are having autism, and they are able to do things that a normal person cannot do. And when we have intellectual disability in autism, that is a comorbidity. It's not a characteristic feature of autism. So understanding what their difficulties are, like what they are struggling with, whether it is understanding the concepts the way they are taught by the teacher or by whoever is teaching them, or whether indeed they have intellectual disability, is very, very important. And then you teach them. Usually they learn better with practical skills rather than just the use of many words. So they want to learn like step by step, short sentences, and which are clear. And you build like one, like for example, if you want to say, go to the house and get me the red plate. You can just say, go, maybe house, red plate, like that. And then they are able to, to put those things together. But if you say it as one long sentence, they may get confused. So it is like looking at what they are able to do, and you build on that. And then you avoid punishments for what they are not able to do, because they are not refusing, they are just either not understanding or they haven't learned how to do it. And then you can also show them how to do it, like by doing practically, so that they can be able to look at the skill rather than having to cram the knowledge. And it's like the way you train a child to use a toilet. You have to teach them step by step, because some of those, they may have missed some of the steps that they were supposed to learn as they grow. So you have to look at what are their deficits, what do they struggle with, how can we start like from the basic principles and teach them these behaviors or these expectations. And if for example they know that whenever they are frustrated they become aggressive, how do you manage that? First of all, you need to know when they are likely to be aggressive, what agitates them, and you try to modify that. And if if like you have they have already been agitated, then you have to speak them, like to talk them down, to take them out of it. Try to understand them. How can I help you? What's going on? Do you need A, B, C, D? Do you want to sit down? Do you want to eat? Like trying to like to give them different options to see which one may be applying in that circumstance. And sometimes the way you respond to them or the way you behave towards them may be the one responsible for their aggression. So you may also look at how do people at home behave towards these people, these children. And then you see whether you can now modify the behaviors of the people around, how they can do things differently. And then the teachers at school, it is difficult for the teachers to do it normally, the way they always do it. People, ideally, it should be teachers who have had some additional training or exposure to such children, because these children will not necessarily learn like others. They may need more time to finish, or they may need more practical things to use to understand. And sometimes, like I can say, like in a developed setting, people with autism may learn better, for example, if they have a computer. Maybe if they are not able to type, if they are not able to write with their hands, they're able to type. But in a Ugandan setting or East African setting, it may be challenging, and the child may be taken as having inability when actually they are just lacking the support they need.
Thank you.
Okay.
Thank you so much, Prof. There
I
are
know we
some
are running out of
questions.
time.
We're running out of time, surely. We started a bit late, so I wanted to kind of borrow a few minutes. But I think we should be coming to the end of the session. There's a question that
Maybe
was shared.
one thing I can mention, Moses, is what we call respite care. Like, if, for example, this auntie of this child is already tired with the baby, with the child, she has carried the big burden for a long time. Sometimes we would mobilize support from other family members, like for the aunt to get some relief so that she can have more grace to care. But if she's always at it, she will become tired and she may start either neglecting the child or abusing the child. So caregiver stress is one of the things that we also focus on. Like if the child does not want to stay in one place, the child is very active. If, as Patricia mentioned, if they are in a place which is not locked up, if they can get like maybe another a younger person who can move around with this child and they play games which require physical activity, that can be helpful and relieve the auntie of the stress of keeping the child in one place. Like if the child can be taken maybe for a walk, and by the time they come back, the child is tired and may settle down. By the way, Dr. Nankunda, you did not tell us about sleep. Sometimes children with autism struggle with sleep. How is the
Professor,
sleep?
oh, sorry. I mentioned the sleep has been good. Sleep and appetite
Yeah.
have not been affected. They are okay.
Okay.
Yeah.
Okay. That's good. Are there any other questions from the members?
There are questions I'm seeing here, but some of them have been answered. Curious about why carbamazepine, that one was answered. Then
Yeah, it is just carbamazepine. As I mentioned, the carbamazepine is just
off label.
trying to see what can we do in the circumstances, what can help with some of these behaviors. But as I mentioned, it is used off label. It's not a recommended medication. But if you have nothing to use, carbamazepine is helpful for those for aggression.
Thank you, Prof. Raymond asked whether the patient has had seizures in the previous episode. I think
She said
Dr.
no.
Patricia said there's no seizures. Yeah, and then Joan was asking, did you consider in your psychiatric sequelae of cerebral malaria, considering the onset of symptoms at 3 years and the history of normal development? I think still here we're still wondering why mother would abandon the child. So we assume probably the symptoms would have started earlier on before the malaria, which we also not sure that it was malaria, most like a febrile illness because there was no documentation. But could this be a neuropsychiatric sequelae, a behavioral kind of presentation? That's my question. Not Joan's.
Yeah, I think most of those questions have been answered, but I have seen a question from who's this? From David Kamia. Could we have considered the necessary, given that hyperactivity and ADHD masks or exacerbates generalized anxiety? Yeah, so yeah, indeed there could be anxiety. Even in autism, people may become anxious. Yeah. And they could also, be having anxiety, which is undiagnosed. So instead of maybe thinking that you need to add an SSRI, you could also first assess to see whether there could be anxiety, whether it is separation anxiety, whether it is generalized anxiety, whether it is social anxiety, and then you see whether there is need, or whether it is OCD, like some of those behaviors that Dr. Nankunda was describing, and then you see whether an SSRI can be beneficial. And remember, the topic was about psychiatric comorbidity, so you need to look at whatever could be responsible for some of these symptoms, or whatever could be a consequence of the earlier diagnosis, and then you manage it accordingly.
Thank you so much, Prof.
Yes, what question haven't we answered?
Mohammed was asking, Dr. Musa was asking in the management plan that we mentioned that the patient is currently on carbamazepine and risperidone. Could you kindly elaborate on how clinical indications for choosing this combination in child with autism spectrum disorder and comorbid ADHD? And I think we had answered that, and how you are monitoring for effectiveness and potential side effects.
Yes, so that's an important question. Yeah, so for behavior in ADHD, actually that we had a study many years ago. I think it was 2016. One of our PCOs who was retired, Elias Biarhanga, we did an audit at Imbarara Hospital to see the usefulness of antipsychotics in the management of ADHD, and we found that it was useless. We were just giving children side effects, but it was not helping with the core symptoms of ADHD, and we stopped using antipsychotics for ADHD. But there is still room for antipsychotics in autism, and I would think that it may be better to have like either risperidone or carbamazepine in this child, since we are not yet sure of the diagnosis, instead of combining the two. Because even carbamazepine can help with the aggression, and risperidone will do the same thing. So if we are focusing on autism as the mainstay, as the main diagnosis rather, then risperidone is better than carbamazepine. But if we think that the diagnosis is ADHD, then there has been research to show that carbamazepine helps with ADHD. So I would think, Dr. Nankunda, that you could just think of just using risperidone only, and you see whether that is more helpful for these behaviors. And Dr. Bengana said, she was asking how do we protect her from sexual abuse? Now, this is very difficult. I don't know who else lives in the home. I don't know how often she goes out of the home to be where she can be at risk. So I don't know, maybe Dr. Nankunda and Dr. Mwangs, you know how the home environment is. How do we protect her from sexual abuse?
Prof, when I discussed with the aunt, she told me she was put in a boarding school. So now she had just come back for holiday. So she has 2 children at home. One is 10 and the other is 6. And I didn't ask for other people around home, but she's also married. So I think it's something we would consider to ask about and discuss on how to protect her from sexual abuse, Prof.
Yeah, it is quite challenging, because this is not only for children with autism or ADHD, but this is generally for even for all the other children. How do we protect them against sexual abuse? Because now it can be by boys, it can be by fellow girls, can be other people around, sometimes the teachers. So how do we protect such a child? It can be difficult. Even in a boarding school, she can be abused by the fellow girls. So it is tough.
It is, and thank you so much for an interesting discussion. And I am reminding everyone who has attended today. This is our very first session. We shall keep improving the sessions, and we shall share a feedback survey to get comments and feedback on how we can improve the sessions. Unfortunately, the president of EAYPTA is not online. He's in another meeting, hasn't been able to join. However, I would really want to thank Professor for sparing your time. So sorry for the short notice and the disrupting your sleep cycle. We are very sorry, but we thank you so much for attending and giving us those very insightful insights. Thanks everyone who has contributed, and on behalf of EAYPTA, we want to appreciate you, Prof, with a certificate of appreciation for your time and the discomfort you've endured to have this session come to realization. We are really grateful. We are going to improve on the management of the case. This has been an interesting discussion, and I think Dr. Patricia, you agree with me that we're going to revise the entire management plan. We are going to do more assessment to see how this child can be managed. In the same way, we also want to appreciate our case presenter. This is it's not easy to sit down and compile a case presented in this way. Well, it's been a quick. We had a very short time period for organizing the sessions, but we really thank you so much, Dr. Patricia, for putting together this case, and this is a certificate of appreciation to you. Thank you so much, everyone, for joining in. This is the very first CME for EAYPTA. We are going to have one every month, and we shall be sharing the links as we go along. And I would really want to request you to keep on the lookout for the next CME. I also I'm reminding you that this CME will have CPD points for those who join. And as you join in, you remember you had to enter your professional number. We thank you so much for sparing your time. It's a weekend. We hope to have our next sessions during the week. The time, we are also going to get feedback about the time, whether we do it in the afternoon or late evening. What works best for all of us is what we shall use. I think I wanted to borrow 30 minutes in 3. It's 3:28 in Uganda. And I would want to thank all of you who have attended.
Moses, I need just make one comment or two.
Yes, Prof. Yes.
Yes, you acknowledge the short notice. I think, when you give enough notice, the presenters can prepare so that it becomes more beneficial, more educational.
Yes.
Yes, so that is very important. But also sometimes people, when they know the topic, they can like share whatever they want to learn about that topic in advance. Maybe ask their questions in advance, and the presenters have those questions so that they are addressed. That one can also help, because I know you all know about these disorders. So if you have a question you have always had, you could share it with the people who are going to discuss, so that that question is not missed. And I also wanted to let you know, I acknowledge 2 people here who are our seniors. Don't think they are young psychiatrists and trainees.
Yes.
But I wanted to appreciate them for being here. Dr. Florence Bengana, one of our senior psychiatrists in Uganda. But as I mentioned, who has also worked in many responsibilities, who has I think one time Dr. Bengana was the head of mental health services in the Ministry of Health and has been at WHO and other places. And then Dr. Sechimpi, who was in charge or part of the group of the private, no, I've forgotten how SHIP, support the health sector. I've forgotten how it is in full. But who was responsible for our training when we were students? He's the one who gave us scholarships for psychiatry. And he's still around, interested in psychiatry, and yet he's not a psychiatrist. He's a public health specialist. So thanks so much again, Dr. Sechimpi and Dr. Bingana, for being part of these initiatives by young psychiatrists.
Thank you.
Okay. Yeah. Those are the ones I can mention, but there are many others. Dr.
you.
Chirabira, are you still young? Are you still a young psychiatrist or no?
No, prof. I'm
Yeah,
about
we
5
say
years.
if you are either 35, 40 or 5 years younger in the whatever. I don't remember whether they changed the rules. But
It was
anyway, there are
5
many
years
people
after
here, and I thank you so much
specialist
for
training.
attending.
Thank you.
Thank you so much, Dr. Sachimpi. Thank you so much, Dr. Florence, for gracing the occasion. We are blessed to have you. And I think